Hi, everyone. This is Amanda Pierce-Kelly. I'm the National Advocacy Director with NAC. Thank you so much for joining us today. We are really pleased to have a wonderful team of folks. We've got our Federal Affairs team, our Advocacy team, our senior leadership, and really the entire NAC team behind us, trying to make sure that we give you the absolute latest information. Things are changing. Some things very quickly right now, and some things are moving a little more slowly. But the point is there's a lot at stake for health centers this year, and there's such an important role that each of you back home can play in making sure there is continued success for the program and the patients we serve. So in general, today what we're going to do is cover the latest updates on the policy side, give you developments in terms of appointees and what we're seeing on the Hill, as well as walk through some of the most important policy elements, including the Medicaid program, health center funding, and the 340B program. Then we'll switch gears and talk a little bit about advocacy and what folks can expect on that side and some of the important things that you should be working on right back home. Just in terms of logistics, if folks have questions at any time during the presentation today, you can go ahead and type your questions in the chat box. That's the best way to get your question in front of us. We'll be taking questions and trying to cover all of our bases at the end of the presentation. So again, if you have questions or you need more information along the way, please go ahead and use that chat box to communicate with us so that we can take your question up live and be as responsive as possible. The other thing that I would share is that we're going to make these presentations available. We'll put a recording and a link to the slides on the Campaign for America's Health Centers website. We will make sure to put that link out across the network using the NAC Washington update and other various communications. You can also always email us at grassroots@nac.com. Usually it takes about 24 to 48 hours before we have access, sometimes a little longer than that, depending on the backlog. But we do try to make sure that we are quick in getting you the information and access to all of the great resources we're going to put out there today. So with that, I'm going to turn it over to our Federal Affairs team to get us started here and walk you through the policy side of the discussion today. And then, as I said, we'll switch gears to advocacy. John?
Thanks, Amanda, and welcome to everybody. Again, appreciate you taking the time to join us today. This is our second in a series of monthly webinars we'll be doing, I think probably for the foreseeable future, as long as things stay nice and complicated here in Washington, D.C., just to make sure you all have the latest. As Amanda said, we're going to go through some of the updates on our overall challenges and opportunities this year, kind of what has happened since our last webinar. We'll talk a little bit about our two priority issues on funding and Medicaid, and then we'll add in one additional issue this time and one next time. This week we'll be doing 340B, and on the next webinar we'll talk about workforce issues. So that really will cover the full gambit of the kind of health center priorities for the year, and then we'll hear from the advocacy team kind of about key steps you can be taking. So major developments since our last webinar, I'll go through these in a second, but just to highlight a major development since we made these slides, which is today was the first hearing for HHS Secretary nominee, Congressman Tom Price of Georgia. And during that hearing, which there were some very contentious exchanges, one of the non-contentious exchanges was that Senator Tim Scott of South Carolina asked the nominee, Dr. Price, about community health centers and asked him his view as a supporter of community health centers, Senator Scott, about what role community health centers will play going forward. And we were really heartened to see that Dr. Price answered with full-throated support of health centers and the role that they play, called them a vital part of the healthcare infrastructure, and really committed to doing what he can as secretary, should he be confirmed, to really advance the mission of health centers writ large. And so, you know, that's a very positive development. A lot of detail to put behind that in the year ahead, but going forward, it's good to know that at least, you know, we have nominal support from the secretary, the nominee. We want to talk a little bit about, you know, what's happened since the last webinar. So, and we'll probably get into more detail on each of these points throughout the webinar, but just to give kind of the high points, both House and Senate now have taken a critical first step but down a very long and twisting path towards repeal of the ACA. And so what they've done is unlock what's called budget reconciliation, a fast-track procedure that lets you move certain kinds of legislation with only 51 votes in the Senate. And they've taken that critical first step to really set up that process. We'll talk a little bit more about where things stand process-wise in a minute. I think there's also been an important change in the narrative around how Congress will be approaching repeal of the ACA. I think coming through after the election was a strategy sort of coined repeal and delay, meaning that they would pass a bill repealing the major elements, say that that would not go into effect for a number of years, and then take those years to really write and come up with what they would consider to be a replacement plan. I think it's fair to say that over the last month, there's been significant pushback on that approach, and really that folks have, especially in the Senate, continued to embrace the idea, or increasingly embrace the idea, that repeal and a replacement plan have to go simultaneously. And then the President-elect, when asked about this in a press conference last week, really backed that up. And so he's also given a little bit more indication, though not a lot of specifics, about what he'd like to see on health care. Importantly, I think he has said now on the record with the Washington Post, he would like to see insurance for everybody, and meaning, you know, we have a new bar, I think, to reach in terms of meeting that goal, and whether Congress in a replacement plan can actually meet that goal. So I think the more he speaks out publicly, the more we'll know a little bit more about where the administration will be coming from on these overall pieces. Importantly, from the advocacy side, and really I think a tremendous success thanks to many of you who are on the call, we did hold both our first ever in-person meeting of all of our state legislative coordinators. We had 49 out of 50 states represented. We also, in conjunction with that, held a targeted fly-in where NAC key contacts, health center key contacts from certain targeted districts came to D.C. And met with their members of Congress to really get on the radar screen early, lay out our agenda and priorities, and I think we held over 100 visits in the course of 2 days. I think by and large they were very successful. I think there's a direct line, frankly, to be drawn from the South Carolina folks. Kudos to them. Being here last week, to Senator Scott asking that question about health centers in this week's hearing. And so we've been really digesting some of the feedback and the reports from that, and going forward, I think it's really going to help inform our strategy. And then last, we will be talking in a lot more depth about this, but we have some really great new materials, including some interactive materials where you can calculate some of the values and the impact of some of these changes at the health center level that we're rolling out as part of this webinar. So going forward, this is a slide that we used in the last webinar, but I think it still remains true, and the questions that we have here that remain unanswered are still unanswered. So again, I think our view is that the future of the Affordable Care Act is really the frame through which all health care discussions will be happening this year. But again, still, even though that process has begun, major questions that you can see here remain unanswered. And I think, increasingly there's a lot of focus on what does a replacement plan look like. Yesterday, the Congressional Budget Office came out with estimates of if repeal only were passed, there would be 18 million people who would lose coverage in the first year after that goes into effect. And so now there are, folks saying, understandably, that a replacement plan needs to cover at least that many people, if not more. And so the bar is really moving, but I think there's a lot more focus, frankly, on what a replacement plan looks like, and then connected to that, the last question, which is what has or doesn't have the votes to pass in Congress, because there are certain elements of replace that are more supported than others, even within the Republican Party, much less between Republicans and Democrats. And as we'll talk about on the next, a couple slides from now, replace takes more votes than repeal, and so that's another complicating factor. So just to return to the process a little bit, we've tried to really keep up to date with this on our blog. but this gives you a sense of kind of the steps involved in a potential process congressionally on repeal and replace. And importantly, the two steps that have already happened, the budget resolution votes in both House and Senate. You can see the passage numbers there, pretty much party line votes. But what we will see now is the development of the legislation that comes after that budget resolution goes into effect. So the actual repeal bill, the actual bill that would do the repeal, still has not been introduced. I think it's fair to say is still being written, and they're trying to, again, weigh all those different factors about what can get the necessary number of votes. I think what you can see here, and we left the strike through on some of these boxes, is that we anticipate the timeline on some of this, that it will be slipping. So when we first made this slide, we thought early February for a House repeal bill vote. We're now hearing potentially late February. Senate, we're hearing March. And so, again, it's just to give an illustration that there are many steps in this process. It's by no means over, and there's a lot of different pieces that are moving. And as Congress really digs into this, it gets harder and harder, and it gets messier and messier, and they really are likely to really slow down the process because of how complicated this is to get a plan enacted, even on repeal, much less replace. So just to get into this, and I think, again, as we've said, when we talked about this a month ago on the webinar, we really saw these as two totally separate steps in the process. I think now conventional wisdom is more towards the fact that repeal and replace will have to be done, if not simultaneously, sort of set up to take effect simultaneously. And so, again, repeal is already underway. The bill that we anticipate would likely undo some of the major pillars of the ACA, including, most importantly to health centers, the Medicaid expansion. But it would also leave in place, we anticipate, some of the other pieces of the ACA. For instance, popular policies like keeping the prohibition on discrimination based on pre-existing conditions, as well as coverage for children up to 26 on their parents' insurance, not to mention some of the mechanisms that created dedicated funding for health centers, the Teaching Health Centers program, our Medicare payment system, and other provisions that were first enacted under the ACA. And so it's unclear right now what replace elements will go along with repeal. As we said, the timeline of all this is very uncertain. We do have some ideas, as we've talked about, of what replace plans could look like, but there's still a lot of detail, I think, to be worked out on that. So I think just in terms of messaging, and this was really carried forward on the Hill last week by all of the folks who flew in, and I would say very, very well received. These are some of the key messages that we'll be hitting, and we are really encouraging advocates to be hitting as you talk to your members about health centers. This is kind of the big picture. It's about talking about the value and the impact that health centers deliver. It's about talking about the innovation that we bring in the system, basing care around the needs of patients and governed by our consumers. It's about how we're on the front lines of some of the most challenging health problems the country is facing. And then we're really boiling down our two top priorities to what we're calling the two key pillars. That is targeted federal investments, again, through the Health Centers program, Section 330 Health Centers Grant Program, and a strong Medicaid program that works for health center patients. And we are strongly making the case that both of those elements must be both protected and strengthened in order for health centers to continue to succeed in doing the mission that they're laid out to do. So just to talk, revisit this slide quickly, as we mentioned earlier, there's really four key priorities. As we've talked about, we really divide this slightly into highest and high priorities. Workforce and 340B, we'll be talking about 340B today, enormously important issues, but Medicaid and the grant funding really foundational issues and part of the two pillars that hold up every community health center. So we're going to today cover in shorter detail than we did last time, but kind of hit the high points on both Medicaid and the grant funding issues. and then we'll turn it over to Michaela Keller from our team to give a little bit of an update on what we see on 340B going forward before we talk about some of the new resources and other things. So with that, I will turn it over to Jen Taylor, our Deputy Director of Federal Affairs and Medicaid guru, who will talk to us a little bit about what we see going forward on Medicaid.
Hi, everyone. Thanks for joining us today. And as you're going to see when I talk through this Medicaid section, I don't know that our ask has necessarily changed, and we're staying on a pretty smooth trajectory from where we were, but there's been some changes in the way that Medicaid is being discussed on the Hill, and so I particularly want to hone in on, what we're hearing that's a little different from last time. But first, I want to give you a quick overview again, just a reminder about why it is that we're talking about Medicaid today. Most of you on the phone, that's probably easy to understand. You see the importance of Medicaid at your health centers every day, but what we're really out there doing right now is reminding folks that Medicaid is foundational for community health centers. Medicaid patients represent about 49% of health center patients and 44% of our revenue, so that's our largest source of revenue. We see the importance of talking about Medicaid on the Hill kind of in three areas that may be challenges for us in the year ahead, but are also opportunities. I think the first is discussing the potential repeal of Medicaid expansion as included in a repeal of the Affordable Care Act. Again, we believe this is still likely to be included in a reconciliation bill that would repeal the Affordable Care Act. That's because it was included last time around when we moved ahead with the reconciliation that was ultimately vetoed by President Obama, but we have still yet to see the legislative language, and so there is a possibility that repeal of Medicaid expansion will either not be included or will be somehow modified in a final bill. And I think we're starting to see a bit of a call for changes in this area, particularly from governors who represent states that did expand Medicaid, that have conservative senators, but they're concerned about the impact that this would have on their populations in their state. We've got governors here in D.C. tomorrow from 10 states, so it's 10 Republican governors, some of whom did expand Medicaid, and they're going to be talking to Republicans in the Senate Finance Committee about the impact that things like the Medicaid expansion and ultimately block grants or per capita caps might have on their states. I think that's going to really be a good indicator of where we go next and how much interest the Congress will maintain in trying to repeal a full Medicaid expansion when people are hearing, about really big challenges in their states back home. The second piece here, again, is the block grants or per capita caps. That would be a fundamental threat, we believe, to health centers for a variety of reasons, largely because the goal of either of those proposals would be essentially to reduce the amount of federal funding that goes into Medicaid programs. And we believe that ultimately, if you're reducing the amount of funding that's going in, there's really, three places where that impact is going to be felt, and that's changes to eligibility, cuts to patient benefits, and reductions in provider payments. That's really the ways in which you can absorb reduced funding to a state Medicaid program. And so all of those obviously raise concerns for us. We want to be, a constructive voice in the dialogue about potential structural changes to Medicaid. This is a much longer-term trajectory than we are seeing in terms of the repeal of the Medicaid expansion. We originally had heard some talk that a block grant or per capita cap changes might be included in initial repeal bill. I think we'll believe that's less and less likely as this conversation evolves. But it also means we may be having conversations about this for months or potentially years to come. This is a tricky one to figure out, and ultimately, when you're looking at the impact on individual states, we believe there would be potentially winners and losers, or some people want to say losers and bigger losers when it comes to states under these scenarios in which they'd be receiving less funding, but we're not clear what the formula or mechanism would be and how much of the federal protections they would want to remove. Ultimately, for health centers, we would also be specifically concerned about either of a block grant or per capita cap proposal that removes all federal protections, because that would certainly include our PPS payment structure, which obviously poses big threats to health center success across the country. The last piece we're thinking of in terms of a challenge is really this push both in Congress and in the new administration for increased flexibility for state Medicaid programs. I want to be clear that in and of itself, state flexibility is not necessarily a problem. We have a payment right now that we believe actually provides for a lot of state flexibility. And in our fly-in last week, we heard a couple of people who kind of said, we're really opposed to state flexibility, so don't do that. I think we want to be clear, it's not being opposed to state flexibility, but we want to talk about what that means in real terms for health centers and where there might be some pitfalls there, particularly legislative proposals that eliminate, again, federal protections like our PPS in the interest of having full state flexibility to decide what they want to do with the funding for their programs. We would worry about the impact that could have on health centers and on their patients. And certainly administratively, as we see a push towards potentially an administration that would approve Section 1115 waivers that could waive our PPS payment, that's obviously of grave concern to us. And so we're in the middle of talking to folks right now about how we can talk to them about what flexibility is already afforded under the program and be constructive in where they'd like to go with flexibility while making clear that there are federal protections that are important to us in the conversation ahead. And that's why right now we're making really two big asks. I think they're going to be familiar to those of you who were on the webinar last time around, and that's first that members support a strong Medicaid program that works for both health centers and our patients. We really see health centers have an opportunity here to play a role that talks about the importance of the services we provide and the provider we are within the primary care system, and also what that means for our patients as individuals and their families in the communities we serve. So I think it's a dual role there in this message, and that's why the second part here, our ask, is that we don't put patients' coverage at risk. We are continuing to talk about the dangers potentially of repealing the Affordable Care Act, including the Medicaid expansion, without a plan for continuity of coverage and access to care. I think that message is, again, resonating. We're starting to hear, as John said, folks really talking more and more about the importance of having a plan in place. So I think that we're going to continue to play a vital role in that conversation, and as we go further, our asks might get even more specific, and that's going to particularly come when we're talking about PPS. I would say another lesson learned for me about our fly-in is that it's been a while since we've had folks on the Hill talking about PPS. And really that's because Congress hasn't considered substantive changes to Medicaid in quite a long time. The last big changes we saw were through the Affordable Care Act in making the Medicaid expansion come to light. But we haven't really talked about financing and large structural changes in at least the last 10, 15 years, and so now that we've got folks again here, we are seeing a number of members of Congress and their staff who are not as familiar with our PPS payment, and even within our own advocates, it maybe been a while since you maybe have never talked to your member of Congress specifically about PPS, so we wanted to remind people today about where some of the strong arguments for PPS are, and I think we're going to dig in deeper into this in the months ahead. I think first and foremost, we're reminding everyone that the health center PPS was specifically designed by Congress to work with health centers, making them more accessible to Medicaid patients. Congress, I think, hears frequently from folks who think Medicaid is a bad payer. It's one of their worst payers, and therefore a lot of providers, don't even accept Medicaid. And that's just obviously different for us by both our statute and mission. We don't turn away Medicaid patients. We don't want to, and we're also not able to. And so Congress had the foresight to say health centers work differently here. They're going to be seeing Medicaid patients, and we needed to make sure there was a stable, predictable payment that worked specifically with the health center model. We know our PPS covers about 82% of costs, so I also would emphasize I think there's folks who maybe think PPS, because it is a strong payment system for us, covers all of health center costs. That isn't true. We're still seeing it covers about 82% of costs nationally, but that's enough for us to have it be a stable and predictable payment, and health centers are smart enough with their dollars to be able to leverage the rest. The other piece there is to remind people that our PPS was also designed to protect the federal grant investment. It meant that if you had an adequate Medicaid payment, health centers wouldn't be forced to take dollars out of the 330 grant, which is intended to provide coverage for the uninsured, to offset you know, the cost of the losses on the Medicaid side. So in order to avoid that cost shifting, PPS was put into place to work specifically alongside our grant, and that's why, again, we're going to be talking about both the grant and PPS and the Medicaid payment as our two pillars of the health center program, and I think that's new information for some folks in Congress who may not realize that's how those two programs matured together. The other thing we want to highlight is as Congress is moving towards prioritizing things, you know, in the system that deliver value, PPS delivers value. Health centers have a really good Medicaid story to tell. I think John hit on some of these points. Health centers serve currently 1 in 6 Medicaid patients, roughly a little more than 15% of all Medicaid patients, for just under 2% of total Medicaid spending. That's a really good return on investment. And we've seen studies show Medicaid savings of 24% on total cost of care when Medicaid patients are being seen at health centers compared to other providers. So we want to remind people that the system as it exists now is providing good value, and where we want to make changes moving ahead, we're absolutely open to having a conversation, but we're already delivering that kind of value that they're looking for, and so they may not need to make the changes within our payment that folks are thinking of. The last thing is we talked about state flexibility. It's really important to remind folks, I think this is definitely resonating on the Hill, that there's already flexibility built into our payment system. Many of you come from states that have a great success story about an APM that you're working on that has, you know, shown great results for both the state and building relationships with the health centers and the state. We love to use those examples. We have members of Congress from states like Oregon who've been very successful, and we now have Chairman Walden and the Energy and Commerce Committee who's going to be making decisions about moving ahead with Medicaid. So I think it's going to be important for us to continue to emphasize where there's been success and the flexibility that already exists, and that's the kind of thing we can build on in the future without having to undermine our payment. The last piece I wanted to emphasize is, you know, we're getting a lot of questions in meetings right now. We put this as our FAQ for this section because we saw it in the fly-in. We've received it ourselves when we're on the Hill talking. Members who are in a changing environment talking about block grants or per capita caps really will ask folks point blank, you know, are you okay with a block grant? What does a block grant look like for you guys? Can you deliver in a per capita cap system, or assume that people would be okay? And I think it's really important for people to understand that, one, you can't possibly speak to all the details of a proposal without having seen it. There is no set proposal on the table right now. We are looking to pass proposals for an idea of where they might be going. But nobody should be able to, you know, is responsible for saying you have all the answers when we haven't yet seen a legislative proposal. So first and foremost, I would tell you that you are in safe ground to say you don't have to answer that question on the spot. And a block grant is not a block grant is not a block grant. A per capita cap is not a per capita cap. That really the devil is in the details about how they're structured, and there's a lot still to be learned about where they're going. That said, I think it's important to lay the groundwork that we do have real concerns about the potential challenges posed by either of these systems. Again, we talked, if your goal is to cut funding to the program, we think there's potentially 3 ways: cuts to benefits, cuts to eligibility, or to provider payments, in which you can really absorb those kind of cuts at the state level. All of those are worrisome to health centers and the patients we serve, and so we would just urge some caution as people move ahead with this conversation. And to, again, flag that we want to work with them. We want to be a constructive voice in this conversation. There is a big education effort, I think, to really get members of Congress and their staff up to speed on what our PPS is, how we work within the Medicaid system, and why we're so important for Medicaid. And so I think that's where we have an opportunity. We want to work together, and I would certainly say if you're hearing this question from your members of Congress or staff, or you're hearing it from your governors, we know folks are talking about before the federal government even moved ahead with a block grant or per capita cap, there are states who are interested in having this conversation back home. We ask you to come talk to us. This is something where we're really going to have to work closely together, and what happens in one state is going to potentially have a big impact on every other state and what happens federally as we move ahead. So if you get asked this question, let us know. We're happy to work with you. And then beyond that, I think Amanda's going to have some good advocacy tips about even when we don't know exactly where the system is going, there are ways we can tell a good story about Medicaid right now.
Thanks, Jen. Yeah, so I'm going to scatter in some advocacy tips because the policy part of this can get really heavy and very complicated. And so the first thing I just want to say to those of you on the phone who may be listening to the presentation thinking, I don't know what an APM is, and I'm not sure what per capita caps mean, or I kind of understand what a block grant means, but I don't feel like I have a handle enough on that to be able to speak to it. Well, that's okay. There are folks both at your primary care association, certainly at NAC, and within your health center leadership that will do the work and may already have the ability to speak to those things. But if you happen to be among the large group of folks who don't necessarily feel super well-versed in that space, that's okay. You still have things that you can do in the context of advocacy when we talk about Medicaid. And at a bare minimum, one of the things that you can do, and by virtue of being on this webinar today, is you can carry this message back to the rest of the network and the rest of the advocacy folks at your health center and say, hey, you know, one of the things we absolutely need to do, and here's your advocacy tip, is make sure that you fill out the Medicaid impact statement that we've put together. And what that does is it arms you with the data and the basic information to be able to tell the story of what these potential issues and impacts and changes might mean for your health center and for your patients, most importantly for your patients. I think the other thing for folks that don't necessarily work in the policy realm day-to-day but may have their hands in the community and or are working with patients on a regular basis, being able to pull out some of the stories, the human side of what this could mean, to speak to what coverage has meant, what it would mean if it went away, and again, to kind of balance the data and the numbers and the analysis with the real side of the human impact of what this could look like. So just quick tip on that, everybody has a role to play in this. Everyone is an expert when they're talking about their experience at the health center and certainly what changes to this part of our reality in the health center world could mean. So just stay on top of this and make sure to have a conversation with your health center network coming out of the webinar to make sure that everybody's on the same page and working together to get all of your needs in order. I also want to take this opportunity, I'm going to turn it over to Alex Harris, because one of the things that we rely on and we look for as a part of these webinars is to get information from you. So we're going to take a moment and just do a poll with everybody on the webinar today. So Alex?
Yeah, thanks. We're just going to do a quick poll about what your health center sees in terms of health center patients that are on Medicaid. Just to get a sense from you guys, obviously it's a huge priority for everyone, but to get a better picture of what your health centers, who your health centers serve in terms of Medicaid patients. So I'm going to give it just a few more seconds here, so we'll make this really short and sweet, and you should be able to see the responses too. So we'll give it just 10 more seconds, guys. All right, I'm going to go ahead and close the poll. And in just a couple of seconds, you should be able to see the results. So you guys should be able to see now the responses. It looks like most of you here fall somewhere between 40 to 60% of your health insurance patients are on Medicaid, and I think the second greatest group here is actually above that, 60 to 80%. So obviously a huge priority of all of you, for all of you, but now we have a greater picture, so thanks for participating.
Great. Thank you, Alex. This is Jen, and I want to move on. I just want to note one thing about the poll, which is about half of the respondents either didn't answer or didn't know the answer, and that's fine. But it really underscores Amanda's suggestion, which is to go back, figure out what these numbers are at your health center. And we use this tool to really try and present that, as well as some state-level data in a really compelling way. I want to switch gears here now and go back over the other pillar besides Medicaid that really we're focused on this year, and that's health center grant funding. As I think folks know, we are back in a year where we've got a funding cliff coming up, And we're going to go over that. We're going to go over what we see, I think, as the outlook for that, what our ask is, and then the same as we did with Medicaid, talk about one of the frequently asked questions we hear, as well as some of the key messaging and an advocacy tip. So just to review, and I hope folks are really drilling this chart into your memory, but the Affordable Care Act created a second funding stream for health centers. In addition to the appropriations that we get every year, there's now also the Health Centers Fund, or the mandatory funding, which is a direct, dedicated source of funding that goes to health centers. That was established on a 5-year basis and then extended in 2015 in legislation called MACRA for 2 years. And so this year, at the end of 2017, we are back in a position where we need to get that funding extended, or if Congress doesn't take any action, health centers will see, on average, a 70% cut to their funding. And so, you know, again, the key points with this, this would affect every community health center in the country if it's allowed to take place, not just those who have added a new access point or had an expansion grant in recent years, although, as we'll talk about, that almost every health center has had new resources come in the last number of years. I also want to underscore, and we'll talk about this more next month when we talk about workforce, but the National Health Service Corps and Teaching Health Centers program, both critical programs for health centers, are also on the chopping block if Congress doesn't take action. And in the case of those programs, all of their funding is really at stake in this question. HRSA has done their own impact analysis on what this would mean if Congress allows the cliff to take place. They estimate that 2,800 sites would be closed, health center sites, that over 9 million patients could lose access to care, and that over 50,000 jobs in health centers would be lost. And I think importantly, going back to, I think, the bipartisan argument, you know, the investments in health center growth started long before the Affordable Care Act. They go back especially to the George W. Bush administration, which undertook a doubling of the health centers program. If this cliff is allowed to happen, it would quickly reverse more than 2 decades of bipartisan investment in health centers. So when we look ahead, just looking at the landscape a little bit, again, important to know that this is one of those things where it's not that Congress would take action to have the cliff go into effect. It goes into effect if they don't take action. And there are a limited number of vehicles, what we call vehicles in legislation, meaning big bills that may be going forward that actually have a chance of passing, that we could attach a fix to in order to get this done before the September 30th deadline. And what is for sure in this environment is that every one of those vehicles is likely to be controversial. We could easily see a bill that makes changes to Medicaid that we don't like paired up with a fix to the cliff, which would obviously put us in a pretty difficult position. One of the other pieces that we're paying close attention to is that other key and critical programs, the largest being the Children's Health Insurance Program, also are set to expire. Either policies or funding streams are set to expire on that same date. And so again, on the good news side, I think there's strength in numbers there, and the more programs expire at the same time, the more there is will for Congress to do something. The challenge there is there's only so much money to go around, and how do you make sure that we get our piece of the pie when it comes to those programs being extended? And then again, to underscore the point, and you know, coming out of the hearing with Dr. Price this morning, health centers really are embraced on a bipartisan basis. This was clearer than ever to us during the fly-in last week. Democrats, Republicans alike expressed strong support for what health centers do, the role we play, and continuing to advance that role. But debate over our issues, whether it's funding, whether it's Medicaid, whether it's 340B or workforce, will be happening in tandem with other debates that are highly divisive. That's just the landscape in Congress right now, and navigating that smartly, staying focused on what we're here to talk about, is critical, I think, over the next, number of months. So to go back over our ask, it's really, again, in 2 parts. Number 1 is at the very least to sustain health center funding on a long-term basis by fixing the cliff. At the very least, we need current services to be funded. but we're also speaking to the need to build in targeted new investments to address both the increased demand, but also the need for stability in the years ahead. I think one of the things Congress is really focused on is they know that the changes that they're making on the coverage side are likely to lead to real disruption in the system. And so how do they make sure that there is stability going forward? One of the ways to do that may be to make targeted investments, new investments in the health center system of care. So the frequently asked question on the CLIF side that we do hear from time to time, and I know that folks here, we want to talk kind of a potential answer for this and give some advice. Congress, does turn to us from time to time and say, look, we've put a lot of money into health centers in the last number of years. I look at this chart, I see that it's gone up, from $2 and a change to almost $5 billion. What do you have to show for it? And so when answering a question like this, we really emphasize first that we deeply appreciate their support. There are a lot of programs in the federal government, there's a lot of priorities that people can embrace, and that we really take our responsibility seriously as stewards of federal funds. And then I think it's important to pivot to a recent example of federal investment and what that has meant at your health center. And that can be any number of things. On the next couple of slides, we'll actually look at all the new investments that have been made over the recent years. But, new access points. Has your health center opened a new site? Have you expanded services at your health center? In particular, Congress is very focused on the behavioral health and the substance abuse and opioid crisis going on right now. Have you invested in quality improvement? Have you built a new building or repaired the roof? What have you done with those federal investments? And honestly, the piece of advice we give here is don't even wait for them to ask this question. We think it's a great way to lead off a conversation with a member of Congress, to go into a conversation with them with a story about a recent investment, as specific as you can get, and really talk about what that's meant in terms of access to care. So just to put a visual on this for a second, each of these bubbles represents a new round of grant funding that's gone out since the passage of the Affordable Care Act. We see here both the service expansions, the new access points, the capital investment, some of the base grant adjustments, and then the quality and IT investments. So every health center in the country has received some of this new funding. This gets a little bit more specific, and again, when we post these slides, you can really delve into the details here. But this gives you an idea, I think, of how much new money has gone out, but also that it's gone to very targeted, very specific kinds of investments that we need you all to be able to speak to when you talk to your members of Congress. And so to talk a little bit about how to speak more specifically to the impact that the CLIF would have at your health center, I'm going to turn it back over to Amanda for this advocacy tip.
Thanks, John. So here's another one where, again, not everyone is necessarily versed in exactly what the numbers look like. What we know is that the primary care funding cliff is approximately a 70% reduction in funding for the program as a whole. So if you go on that assumption, what does that look like for your health center? Now, glass half full or empty, depending on how you look at it, is that we've been through this once before, and so many of you have probably already at some point used our CLIF impact estimator. What it does is it allows you to plug in specific health center numbers, which then produces a report, which you can see here on the screen, that's health center specific, that tells the story, again, in terms of those numbers. So just in terms of the tip, if you haven't done it since the last go-round, it's time to do it again, because we really do need to know what the numbers look like, what that impact is going to look like in terms of that cliff. But as I said before, I think the other thing in the role that every single person on the webinar today and everybody back home has to play in this discussion is making sure you can speak to the human impact of that. It's one thing to talk about the numbers and what this looks like in terms of the data. It's another thing to actually tell the story of what that would mean to your community, to your staff, to your patients. to your services, all of these different things, because there's a very real impact here. So again, whether you're the one who's dealing with the numbers and crunching, data at your health center, or you're somebody who has your hands on the patients, or any number of operations in the health center world, or perhaps you're a partner or volunteer, the point is being able to speak to this in an eloquent, articulate way and really tell the whole story, numbers and human together. So here's your advocacy tip. Make sure that you're taking care of getting your data in order. We do have that estimator tool, which we'll get into a little bit later on, but that's your tip for today. When you get off the webinar, if you're not the one actually executing on this, hopefully you're having a conversation with your health center network and your leadership to make sure that this box is one that you can check. Alex, are we going to do another poll? I want to make sure we leave time for that.
Yeah, so I just opened a quick poll. So it's simple yes or no. Did you complete the CLIP Impact Estimator the last go-around when we released a similar tool to try to show your story about what a potential 70% reduction in funding would look like? So have you completed this tool previously in years past, or even have you already done it this year? We just kind of want to get a sense of whether you guys have use this tool yet or not. And of course, we always love to hear your feedback, so feel free to share that too in the chat box. But I'm going to give it just about 10 more seconds, and then we'll close the poll and you guys can take a look too. All right, I'm going to go ahead and close that. We'll wait for it to close. And just so you know, guys, I'm getting a lot of questions about where some of these tools are posted, and I'll make sure to put the link in the chat box, but it is at saverchcs.org/makethecase.cfm, and that's where you'll be able to find all these tools, including both the Medicaid and the CLIP Impact Estimators. So I'm going to go ahead and show you guys the poll results. And it looks like it's pretty split about whether you guys have done the CLIP Estimator before or not. So always a good opportunity to go to our website and check out this tool and take a look at what these numbers look like for your health center and your community.
Okay, so with that, I think we've covered again and hopefully, updated you a little bit on the two key pillars that we're focused on going into the year. But those aren't the only things that are on the legislative agenda this year. And so we did want to take some time this month to talk about the 340B drug discount program. I'm going to turn it over to Michaela Keller, who's our Manager of Federal Affairs and 340B guru. We have a lot of gurus over here. And to kind of go through in a little bit more detail what the landscape is on 340B.
Great. Thanks so much, John, and good afternoon, everyone. As John mentioned, we did just want to take a little bit of time this afternoon to talk about 340B. As we know, this is a program that is increasingly important to health centers, particularly in light of the potential threats around the CLIF and Medicaid that we've just been discussing. But also as we try and read the tea leaves around here in this current environment, we see 340B as one of the issues that could potentially be introduced in this Congress, whether that is through standalone legislation introduced by an individual member or through a series of reforms included in a larger health care package. We are sort of just trying to get a sense for what possibilities are this coming year. And I just want to be clear that there currently is no legislation introduced in Congress. We just wanted to talk a little bit about where this program has been in the past couple of years, what we've been hearing on and off the Hill, and what we can expect going forward. I also just wanted to highlight that I will be talking about this program from my perspective in our federal affairs team and what is going on or not going on the Hill. We know that there are a lot of 340B issues going on in the states, particularly around managed care and the covered outpatient drug rule. I won't be getting into that level of detail on this webinar, but I do encourage you, if you do have questions or you're looking for more information, that our colleagues in state affairs and regulatory affairs are great contacts, and anybody on this webinar can certainly put you in touch with those folks. So before I begin, I also just wanted to highlight that 340B is an issue where there's great variation in terms of knowledge on the Hill. You will see some staff and even some members that have some great familiarity with the program, and then you'll see others that have no idea what this program is, and that may be the case for some of you on this webinar today as well. So I thought I'd just start a little bit about the basics of the program before going into sort of our outlook. And so just to begin, the 340B program is a program that was created by Congress to allow safety net providers, including health centers and what they consider covered entities, to obtain outpatient drugs at discounted prices. Congress created this program with the intention to allow these safety net providers to stretch scarce federal resources as far as possible to reach more eligible patients and to provide more comprehensive services. And when looking at the role of health centers within the safety net, we certainly feel that and this sentiment is echoed on the Hill, that health centers are the type of safety net provider that the 340B program was intended to support. Additionally, health center participation in 340B has bipartisan support in Congress, and in general, 340B isn't necessarily a partisan issue. We see members on both sides of the aisle that have come out in support of protecting the program as it currently is, and others come out in support of making changes to the program. And I think that largely is dependent on members' district, whether they have more vocal hospital representation or they have more vocal drug representation could certainly sort of sway a member's outlook with respect to this program. So I did just want to highlight the two last bullets on this first slide, as these are really messages that we found resonate really well when talking about this program on the Hill. The first being that providing access to pharmacy services is a key component to our health center comprehensive care model. And the second being that by statute, health centers are required to reinvest the savings from the 340B program into their HRSA and BIPIC approved scope of project, and that advance their charitable mission. And I'm going to go into a little bit more detail about these last 2 points, but did just sort of want to dive right into the outlook and what we've been hearing with respect to this program. And so largely a lot of the increased attention to the 340B program has sort of revolved around this debate between hospitals and drug manufacturers over the proper scope of the program. So the drug manufacturers believe that in general, this program has grown sort of beyond its original intent, while the hospitals want to preserve the program in its current form because they feel that this, as it currently stands, allows them to reach more eligible patients and provide the full range of services to low-income and other patients that they serve. So largely in response to this debate between these two stakeholders, Congress and the administration have made a couple of attempts to make changes to the program. We saw this first back in 2015 when the House Energy and Commerce Committee tried to include some language to make some changes to the 340B program as part of their 21st Century Cures bill, largely due to the process by which they tried to include those changes as well as the changes themselves. There was a pretty big outcry from the stakeholder 340B community, and that language ultimately wasn't included. But we saw the administration then take a stab at making some changes later that summer when HRSA introduced their proposed omnibus guidance around the 340B program. To date, as many of you know, HRSA has not released that final guidance, and I think it's fair to say that in the last 3 days of this administration, we don't see them releasing that guidance. So really, what that all leads to is that many suspect and expect that the stakeholders that are looking to make changes to this program will, again, look to Congress and look to making changes via the legislative route. At the same time, there's also been a good amount of reports and activity from outside interest groups looking at various aspects of the program. And to us, that signals that Congress is really looking to do their homework and to address some of the concerns and issues that have been raised over the coming years with respect to 340B. So I say this all just sort of to conclude that, you know, where does this leave health centers? I think much of the scrutiny in the program is really directed towards the hospitals and the drug companies. And going back to the previous slide, I think it's safe to say that health centers can make a very strong case in terms of their participation in the program, that providing affordable medications is a key component of our comprehensive care model, and that by statute we are to reinvest all the savings into advancing our charitable mission. And so while the scrutiny isn't directed at health centers, we very much want to be a part of any conversations and any sort of discussions about making changes to the program, because we just want to ensure that any changes that are made do not unintentionally impact health centers and the patients that we serve. And I also just wanted to highlight that while there may seem to be some momentum to make legislative changes to the 340B program, it's important to view that within the context of the larger healthcare debate that's going on right now. 340B is a relatively complicated and obscure program, and so when you look at all the other healthcare issues on Congress's plate right now, it's really hard to say where this falls in the list of priorities, but we certainly are keeping a very close eye on that, particularly as Congress potentially looks at drug pricing. We certainly see that as an area where 340B could be raised. And so for all these reasons, we did want to just put together some asks, even though we know there isn't any draft language out there currently in Congress. We feel it's helpful to have just some straightforward and simple ways that if you are asked about 340B, that you can sort of talk about our unique role in this program. And so the first, as you see here, is just to preserve health centers' ability to stretch scarce federal resources through continued access to 340B. And then secondly, if changes to 340B are being considered, that Congress take into account the unique role of health centers and other grantees. And again, we have just some arguments really to back up these asks. The first being that this program does allow us to stretch the scarce federal resources that we get. And we are able to do that by providing more comprehensive services, whether that's hiring a pharmacist or behavioral health provider, or being able to stay open longer on the weekends. And again, this program is essential to the affordability of prescriptions that we provide for our patients. And lastly, as Congress considers changes to the health system overall, we know that health centers will continue to rely on 340B as a means of stability. So we need to be a seat at that table when discussions are taking place. So I'll just end by saying that certainly if legislation is introduced, we will do a full analysis and keep everyone up to date on that. But in the meantime, we just wanted to talk a little bit about what we're seeing and hearing and how we're reading the tea leaves. And certainly if you have questions or want to talk about this further, I am happy to chat at any time. But I did want to turn it over to Amanda, because even if anything I said today made sense or didn't make sense, this next point that she's going to bring up is really key in terms of communicating to Congress the importance of this program for health centers.
Thanks, Michaela. So there's a common theme here that you're going to hear from me, both in terms of these advocacy tips and I think across the board, and that is some of you may be hearing about 340B for maybe not the first time, but more in-depth than you ever have in the past. And I think the takeaway here is that it is a very, very important program to the health centers program, to being able to fulfill our mission and provide enhanced services to our patients and to the communities. And so the one thing I will say, part of being an effective advocate is staying informed. And so if you have questions and you want more information about the 340B program and how it interacts with your health center, please don't be shy about reaching out to our staff and certainly talking with your leadership and your primary care association. It's a really wonderful program, and as I said, it is a huge priority in terms of making sure that we can continue to fulfill our mission across the health center program. And I just hearkening back to the webinar that we did last month, John and I know his team have sort of described our policy priorities this year as high and highest. So the two highest right now have to do with Medicaid and our health center funding and the primary care funding cliff. The high priority, one of the two, is 340B. The other, which you heard us mention at the beginning, is workforce. So I can't stress enough the importance of doing your homework, getting the information on this, and you'll see the advocacy tip there, being able to speak to at least one good example of how this program supports your health center and your patients and your community at large. If you are not in a position to answer that, which of course, you know, some of us work in 340B and this part of the health center world, and some of us do not. But I think carrying this message back to your network, to your leadership, to your colleagues, and being able to have a conversation about what does this program mean for our health center. Do you have a full-time pharmacist, and is this 340B program a part of how that's able to happen? Are you able to expand your hours? Is there a wellness program? Just any example you can provide that links back to the importance of what the 340B program does for your health center, your community, and your patients is going to be absolutely critical as we advocate for this program going forward. So with that, John, do you have any last remarks, or do you want to wrap it up on the policy side?
Sure. I do want to just kind of, you know, try and pull everything together here. I think folks have gotten a sense today, hopefully, of how things have progressed and not progressed on Capitol Hill. We do continue to expect that, you know, this debate is moving forward one way or the other. And, you know, we can't see everything in the crystal ball, but as it moves forward, we do feel like health centers are well positioned, and we feel like we will be able to keep you informed, and we need you to stay engaged going forward. But, you know, if there's a bottom line message, if you're meeting with your member of Congress tomorrow, many of you met with them last week, but if you're going to see them out in the district this weekend, or they're coming to the health center sometime soon, what are you going to say? Number one, again, I think first and foremost, underscoring that health centers are one of the few things in healthcare these days, especially at the federal level, that both parties agree on. And so, therefore, as Congress is debating the future of the health system, we really need to be part of the solution, and we're ready to be part of the solution. Going back to those two pillars, again, health center grants and a strong Medicaid program are the two pieces that make up our success, both in delivering that access, but also in delivering value and delivering cost savings, in delivering care and access well beyond the percentage of these programs that we take up. And so really putting health members on the spot to say, will you support fixing the health center funding cliff, and will you work with us to ensure that Medicaid continues to work for our patients? And then, frankly, still, we need to be expressing concern about any plan to repeal the ACA without a clear plan to replace it. And what we mean in terms of replacing it is making sure that it has at least the same impact on our patients, that we can't have the solutions being put forward create a world that is worse for our patients who've gained coverage or gained services or gained access since passage of the ACA. So that's kind of the bottom line. I do want to turn it back over to you, Amanda. We'll be here to answer questions at the end, but I know you're going to do a quick advocacy update with some other key steps that folks can be taking right now with their members of Congress.
Great.
Sorry for the background noise.
Everybody can be glad that they're not listening to the crazy sirens and protests going on in D.C. right now. While we switch over controls so that I can advance these slides, you'll notice what's in front of you. It's a brand new logo, brand new look for the Health Center Advocacy Network. We're going to talk a little bit about that later, but we're really excited to give you guys a sneak peek at sort of a new look and a new identity for the Health Center Advocacy Network. And John and Alyssa, if you guys can turn the controls over to me and or advance that slide, that would be perfect, and we'll keep on moving. Just a reminder to folks, if you have questions, you can go ahead and type those in the chat box, and we will take them up at the end of the update. All right, so switching gears here, making the case with advocacy. There are a few steps that folks can be active on. You heard me mention those tips, but there are a couple other activities that folks can be working on immediately coming out of the discussion today. So let's dive in on those. The first is, as I said, staying informed, making that commitment. To be effective as advocates, you don't have to know every single detail or be an expert, but you do need to do your best to stay informed and up to speed on what's happening so that you can feel comfortable when you're talking about your health center and delivering this message. So there's a variety of ways for you to do that. The best and the most simple way to stay informed is by signing up as a health center advocate. Hopefully everybody on this webinar has already done so, but if you haven't, you can go to saveourchcs.org and click Join the Campaign. That will plug you into our advocacy network. It will give you access to our weekly newsletter. It will also provide you access to calls to action, which we try very hard only to send out when it is appropriate and totally necessary. The other thing you can do for those of us that are glued to our phones, which is the majority of the world these days, it seems like, you can become a text advocate by texting HC Advocate to 52886. But the point is, get involved, sign up. And lastly, we are going to continue with these monthly webinars, and the reason for that is things are changing and happening very quickly. Congress is making determinations, and frankly, everything that we've talked about today is not just centered in Washington. There is so much activity going on at the state level. Please understand that when we talk about advocacy, we talk about these updates, there's a direct correlation to what's going on back home. It's not just what's happening on Capitol Hill. So one of the best ways to stay informed on those latest updates is to tune into these monthly webinars. You can see the dates there. February 22nd is the next scheduled webinar. There's a link, obviously, to sign up. It's always at 3:30. We book an hour and a half just to make sure we've got plenty of time to get through the content and take questions. So next piece here, going back to a lot of the tips we already talked about, I'm not going to belabor this, but please, coming out of this discussion, make sure that you work with your leadership, your board, your whole health center advocacy team to make sure that you've completed both the updated CLIF Impact Estimator and the template Medicaid Impact Statement. That's going to give you the data and the numbers and the analysis around what these two areas of policy could mean and proposed changes might look like for you on the ground at your health center and for your patients. The other piece, as I mentioned, which is equally important, is being able to speak to the human impact. So once you've done these analyses, what does it actually mean? On the CLIF side, what does it mean in terms of your services, your staff, your community, your patients, your ability to fulfill your mission? And on the Medicaid side, the same thing. What story can you tell about folks that have either gained coverage or would stand to lose it if there are potential changes? What does that look like in the human form? So make sure you're staying on top of that and working with your network to get a good handle on what that picture looks like. And again, both of those tools can be accessed on the Campaign for America's Health Centers website. It's www.saveourchcs.org. The last piece here, and this is one that you've heard us talk quite a bit about repetitively for the last couple months, and it's not going to change, is building advocacy capacity at your health center. The reason is not just to affect policy and the proposals that are coming at the national level. This is so you can be effective and successful at the local and the state level as well. It's critically important that everybody step up and get involved. There's just too much at stake this year not to do so. In particular, we are encouraging every single health center to work with their primary care association and with NAC to become an advocacy center of excellence. Utilize the ACE program. There are very clearly outlined steps for building your advocacy program and your capacity from the ground up. You will receive national recognition upon doing so, and there are a ton of resources to support you in this effort. Once you've done that, once you've become an advocacy center of excellence, there's no stopping you. There's nothing that will stand in your way of being effective and having the success in your advocacy going forward, and we're going to need your help. We'll be calling on you many, many times over the course of the next many months, both in terms of national issues and certainly at the state level as well. The next piece here, and as I alluded earlier, we're really excited, something coming soon, lots of new key resources for advocates. We're going to be unveiling a brand new advocacy website. This is our new look, the Health Center Advocacy Network. Please save the date for March 15th at 3 p.m. We'll be having a webinar to launch the Health Center Advocacy Network website. the reality is that we've grown. We're over 100,000 strong, which is very exciting, and it's a big, big testament to the work that you all do in the field every day and your commitment to advocacy. And so as we've grown, we need to keep up and grow as a network and as an entity. And so we will be driving the Health Center Advocacy Network forward. Brand new look, as I said, brand new website. So look forward to that webinar again on March 15th, 3 p.m. There are many resources that we've put together to support you in your advocacy. You've heard us reference a number of them. As I said, all of the webinars and the recordings will be available on the Campaign for America's Health Centers website. You're definitely going to want to register ahead for February's webinar. Just get it in your calendar as soon as you can. But look also for talking points. We have one-page policy papers. There's a Medicaid savings study that we've been using quite a bit to be able to tell the story in the bigger picture, those estimator tools, and lots of other great resources. If you are looking for something that you don't find, and you can see the web address there is saveourchcs.org, make the case. If there are resources that you don't find, please don't be shy. We are happy to work with you to either create something, or it may be that we have a tool or a resource that we have not posted for the sake of keeping things simple and easy to access. So again, take advantage of those. Make sure that you're familiar with what is available to support you in these conversations. So with that, I think we've completed the content side of this, and hopefully there's plenty of time for questions. Alex, do we have anything that's come through in the chat box that we want to take up?
Yeah, we have some great questions, and guys, feel free to continue to write your questions in the chat box. If we don't get them to them today, we'll try to follow up with you guys directly. But I have a question here regarding Medicaid. It says, Medicaid and expansion are like four-letter words in my state. Is there another way to frame the message so we're talking about expansion and Medicaid without saying really those words? They say, I'm not even sure access is really acceptable. So any thoughts or suggestions for advocacy on Medicaid?
That's a tough question.
I can chime in. I was going to say, we're not stumped. The silence doesn't mean we're stumped, guys. Jen, I can take a stab, and then I will turn it over to you as somebody who has this conversation every single day on the Hill with a variety of folks and audiences. I would say just any time you are caught in a tough conversation, telling the health center story will never do you wrong. And so I think being able to speak to what you do at the health center every day and what that looks like in the context of the current system, that's a safe space, and certainly one where we have seen wonderful bipartisan support. It's obviously very difficult to navigate those, landmines, but I think being able to come back to that space each and every time, no matter what the context, should be a great starting point. Jen, do you want to chime in?
Yeah, I think that's exactly right. I would start there, always being able to tell the story about what happens at your health center, being able to tell the story of your patients and, keeping it local. I would say a couple of other things on top of that is, one, if you're not a Medicaid expansion state and that's not the place where you want to spend your advocacy efforts, I think you don't have to delve entirely into the expansion conversation specifically if that's a little bit more politically tricky. I think still being able to tell the story of Medicaid broadly at your health center is an important one if you're able to do so. The other reality, we do have two pillars of, CHC funding and support that we're talking about this year, and if CLIF is a stronger story for you, well, I don't think you want to entirely dodge or say Medicaid is not important. I think you can really focus your story on what is most important at your health center. If your health center is more heavily reliant on CLIF, or in your state that is a much bigger concern, I think we gave you tools to be able to tell both of those stories, and I think you can emphasize the one that is strongest for you. So I urge you to make it local, tell the story that works the best for you back home. I would also say that one other thing that's interesting for us within the world of Medicaid is even in places where Medicaid may not be seen in as positive terms, we have a really good story within Medicaid to tell, and I think that's a really unique role for us where we can say, hey, maybe you hear the story of how Medicaid is a bad payer. Maybe that does sound like a four-letter word from most people around here. What I can tell you is that's not always true, and in the case of health centers, here's a really specific, unique, and important story we want to tell. So even if you want to see bigger changes broadly, at least know that within Medicaid, we do provide good value, we do have an important story, and you can put that little bug in their ear that maybe somewhere in the back of their mind, Medicaid isn't quite as scary a four-letter word as it might sound, at least when it comes to health centers.
Great, thank you all. So I have another question here about just general changes with the healthcare system and what we might expect to see. They say, I have received very direct questions from legislators and reporters asking what we would propose, not just what we are against or what we want included. They are interested in our solutions and our comments in regard to costs associated with the ACA and fixes to the bill. What suggestions do you guys have for people who are receiving those types of questions?
I think that's a terrific question, and it's one that we do run into happily, I think, on Capitol Hill, where people say, look, I understand what health centers do. I understand the role you play, and I'd like to make you a bigger part of the solution. How do I do that? And so I think that there are a couple answers to that. I think first and foremost, it is still important not to say what we're against, but the importance of start by keeping us whole. I think it's important to point out, whether it's a legislator or a reporter asking those kinds of questions, that the pillars we keep talking about between health center grant funding and Medicaid are fragile. And if we're going to play a larger role, which we want to play and which we have a good case to make on, we need to start by putting some stability in place, both on the grant funding side, but also through Medicaid. So I do think it's important, before entertaining that question, to start by saying, let's keep us whole. I think the other thing that moving forward to really point out is that, because of that bipartisan support, we do feel like there's a larger role for us to play going forward. There is an enormous amount of need that is still unmet by health centers. We serve some 25 million people today. The best estimates we have are that more than 50 million people are still without a regular source of primary care. And as the healthcare system moves more towards looking at value, talking about the value of primary care specifically and of health center services specifically is a place that we want to be putting more resources, a place that we want the system to incentivize more directly. And I think, we have some ideas on how to make those changes. I'll be honest when I say that we're pretty focused on navigating the current environment by staying whole, while also making the case that part of achieving stability in a disruptive environment is making some additional investments, I think, on the health center side. And so it is a good question. Start by talking about making us whole. I think emphasize, the value of primary care when we're talking about larger system changes, and that's not controversial. That's something that all members understand. Again, beginning with the potential next HHS Secretary, Congressman Price, today really spoke to that, I think, very, very directly. So that's kind of where we come out on that.
Great, thanks. So I have a question here, a couple of questions actually about 340B, really asking what is the real concern about this program other than the fact that it is expensive, and who is opposing the program? Who are the folks who are mostly critical of it?
Hey, Alex, thank you. That's a great question. So I would say in terms of the criticism of the program, a lot of that is directed to sort of the growth of the program in recent years, most specifically on the hospital side as more entities have become eligible for the program, as well as the expanded use of contract pharmacies. I think a lot of that criticism is directed to the hospitals from the drug manufacturers. And I think there's also another big issue around how savings from the program are used at each eligible covered entity. I think one of the criticisms is that for some, these savings have become somewhat of a slush fund that are not necessarily going back to, expanding services to patients or providing patients with lower cost drugs. And so that's sort of a big criticism that we hear, and that's why I think it's so important to the point that Amanda brought up in our advocacy tip to really think about how those savings from the 340B program are being used at your health center, because you want to be able to directly answer in a way that shows that you are providing more comprehensive services and are allowing patients to receive discounted drugs through the use of this program. And so, I would sort of just touch upon those as sort of the major criticisms, where they're coming from, and how you can sort of prepare yourself for that criticism.
Thanks, Michaela. So here is a question we have about what folks have been hearing a little bit about family planning. So this person asks, what is happening around Speaker Ryan's comments about health centers taking on funding and services for family planning?
So I'll step in and speak to this one a little bit. I think folks are aware that as part of the CNN town hall that he conducted earlier this week, Speaker Ryan did speak to, in response to a question about family planning funding, specifically funding for Planned Parenthood, speak to his preference that those resources be directed to health centers. And this is not a new narrative. It's something that we have been hearing over the last couple of years. And we did have some really good discussion internally last week with our state advocates and with our key contacts about how people feel comfortable answering this question. First and foremost, it's important to know that in no way has NAC been advancing that narrative. We were not the ones to propose that as a solution. But I think if you're put on the spot with that question, which is obviously a difficult question, I think the important thing, like with all of our advocacy, is to start by telling the local story. What is your role in providing family planning? Family planning is a required service at every health center. We provided contraceptive services last year to over 1 million patients. So we are providing some services. It's not the only thing we do. But what are you providing today? What is your capacity to absorb additional patients if other providers in the system lose their funding? What is the relationship that you have at the local level, and what does each provider mean to the local system of care, especially when it comes to care for underserved patients? I think the second thing to do is really to stay focused on the funding issues that we have coming up very quickly this year. And so I think it's fair, if you're put on the spot with this question about do you have the capacity or not, to really pivot over to talking about the funding cliff and say, I'm not in a position to talk about capacity at all until I get the 70% cut that's hanging over my head come September addressed on a long-term basis. The last thing I would say, and again, because this is a controversial and difficult issue, is please reach out to us. We have been having this conversation, again, we've not voluntarily, but we've been responding to this question a lot as of late. We are happy to talk it through with you and really figure out how you can give both the most direct and the most honest and the most straightforward answer that you can give. It's a complicated issue, but I think if you can tell your local story, and then frankly, if you can say, we have our own funding problems that we're very concerned about, because I don't think there's as much awareness of that, understandably, but I think if folks knew that there was a $3.6 billion hole coming for health centers, I think they might see this situation a little bit differently. So that's kind of our read on that situation, but please do not hesitate to reach out to us directly.
Great, thank you, John. So with regard to timing, we have a question here. They say our health center has gotten funding for 2017, and in terms of any potential Medicaid cuts and, of course, the potential for the cliff, would that happen in 2018, or what are your thoughts on that?
So I can speak to the potential impact of the cliff. If Congress doesn't take action, and again, we all are pushing them hard to address this early and on a long-term basis, but if they don't take action, that funding would no longer be available after September 30th of this year. And so we don't know exactly how HRSA would implement such a cut. We don't know exactly on what timeline they would implement such a cut. What we've heard in their correspondence with folks on the Hill is that they would have, you know, a couple of months basically of reserves before they had to start making big real cuts. But so, you know, I think that that would go into effect relatively quickly. Now, does that mean that if you got funded this year that you should be holding back, that you should be cutting back on staff, shutting down programs in anticipation of this? No. I think what it means is you need to think about what are those programs that would be cut when you fill out your CLIF impact estimator. We're going to pitch that one more time. Put together a story of what you would have to do. So you have to do the thinking about this, but then really communicate that to your member of Congress. Channel that energy into your advocacy because we are not optimistic necessarily, but cautiously optimistic, I think, given that Congress has done this once already, that we feel like they, you know, understand the importance of this funding, and I think that we heard many times last week a commitment from members to take action on this. We're by no means out of the woods, and we need everyone engaged, but I wouldn't start changing, you know, the actual structure of your program based on that going forward. And I'll let Jen speak to, you know, kind of the unanticipated timeline on the Medicaid side.
And the timeline on the Medicaid side is actually a little bit less certain in a variety of ways. It's a little more complicated. While we do have a drop-dead date on the CLIF side, you know, Medicaid changes don't have to happen. They're just on the table for consideration, and so I think that timeline is going to be a little more nebulous. We're looking right now at the consideration of the repeal of the Medicaid expansion would be the first thing to happen. If it does happen, we would be seeing that likely sometime in terms of February or March with the legislation going into place, but that may still accompany a delay in it actually taking effect. So depending on whether or not this repeal and replace plan, and there's several steps. I'd say one, depending on whether Medicaid is included in the repeal, and then two, depending on whether repeal and replace happen simultaneously or they, you know, do move back towards the time frame of putting in a delay. We're not going to see, I don't think, Medicaid expansion fall overnight. There will likely be some time frame in which that is wrapped up, and we just don't know what that is yet if they do move ahead, again, with the expansion, which isn't for certain at this point. The second piece of this in terms of a block grant or a per capita cap, we could be looking at a much longer time frame before something like that were to go in place. We certainly wouldn't be even seeing legislation to specifically move ahead with that until later this year at the earliest, and that would come along with a long time frame to make changes in the states before they were ever able to get that up and running. So there would be a lot that would have to happen on the congressional side to get a bill like this moving ahead, and there's, I think, a long conversation before they decide in agreement upon the details of what such a plan would look like. And then beyond that, there would be a long implementation process that a new administration who's still figuring out their priorities, who doesn't, you know, honestly probably yet know where the bathrooms are and how to turn on their computers, would have to take until they're able to be up and running in a place to institute an entirely new approach to Medicaid. So I think we're talking about a much longer time frame. And while the importance for advocacy is now, because those conversations are happening and people are starting to formulate their opinions about what is and isn't possible and where they'd like to go, we're not likely going to see actual on-the-ground changes in Medicaid for quite some time. And so, again, the urgency is now, but I wouldn't panic overnight. Like, let me assure you, states will continue to take every dollar of Medicaid expansion funding as long as they can. They will continue, you know, unlike our CLIF where there's a date certain that that funding would end, that isn't true of Medicaid right now. And so I'd urge you to continue on the path you're on, but engage in the advocacy as soon as you can.
Great. Thanks, John and Jen. So one more quick question, and then we'll wrap it up. Somebody is asking, other than, you know, health center leadership and the folks that are deeply involved in policy and advocacy, what can other staff at health centers be doing to really make an impact and support health centers?
I think I'll take that one, guys. I think being able to speak to your story, how did you get involved with your health center to begin with? What do you see there? Why is it important? What is it doing for your community? What do you see the value is to your patients? You know, the one thing I will say about advocacy, and certainly when we talk about health centers, is that you are an expert when you talk about your own experiences. And there are a lot of really important causes out there, but there's a reason why each and every person that's on the webinar today and each and every person that's touched by a health center has chosen to stay involved. And so that's as much of what advocacy is about as the policy piece and the data and the numbers. You have to have both. And so I would just encourage folks, if you are not someone who works in the operational side, if you're not someone who, deals with the policy on a day-to-day basis, the best thing that you can do is make a commitment to raising your voice on behalf of health centers, speaking to your experience, and again, why your health center is important to you. And I think also being a squeaky wheel at your health center in whatever capacity you are involved. I think that sometimes it takes a number of voices to say this is really important and we have a very important role to play, and our voice is critically important in making the case for the value of health centers and the importance of the program and the system as a whole. And if we're not going to do it, then who is? And so it's incumbent upon you, that's your role, to raise your voice, but also to encourage your network and those that you touch at the health center to make sure that they understand the importance of stepping up and using their voice as well. So there's a lot of things that you can do, and again, we have the slide back up on the screen. One of the best ways to stay informed is to join and become a health center advocate. There's a few different ways to do that. Continue to participate in these webinars on a monthly basis so you can have the most current information. And don't be shy. We really, really appreciate hearing from folks across the board at NAC and certainly in the Public Policy and Research Division. And a lot of the information that we provided today is pretty heavy and detailed. So don't be shy if you've got questions. Reach out to us anytime. And with that, I think we are over time, actually. So I'm going to sign off for now and just say thank you all so much for participating today. We appreciate your support and your advocacy and your voice, and we are very fortunate to have you all back home doing the hard work. So stay in touch, and we'll look forward to speaking with you again next month, and in the meantime, as things come up. Have a great day. Thanks a lot.